Professor M.Pepi.
Dear George, dear friends, it's a really pleasure to have this meeting with you. And the dysfunctioning prosthetic valve, how to define and manage, is my topic. So, starting with the first slide, I have no conflict of interest. As general rules, as you know from the guidelines, when we evaluate a prosthesis, we should have the data concerning the patient's symptoms, type and size of a prosthetic valve, the date of surgery, the body surface area, and to have and define the baseline characteristics, sorts of fingerprint after the surgical procedure. So what is abnormal in terms of gradient? Generally, for the mitral prosthesis, any mean pressure gradient above 8, or for the aortic prosthesis, this depends on type and size of the prosthesis. The estimated annual rate of mitral valve thrombosis is variant from 0.1 to 5.7, and we know that the higher rates have been seen for the tricuspid, more than the mitral, more the aortic. And the clinical presentation can range from an incidental finding in an asymptomatic patient, but also to cardiogenic shock. So I will discuss easy diagnosis in critical ill patient, difficult diagnosis, high aortic gradient, and therapeutic decision. Starting with a case of a cardiogenic shock with a mean gradient of 30, no doubt this is an easy diagnosis, the thrombus, the very, very high gradient. Another case, similarly, we have not a large thrombus, however, one leaflet is stuck, the second one is hypomobile, and the mean gradient is 29. A patient in New York heart class 3, and you see that the gradient is 18, and you see that one leaflet is stuck, the second hypomobile. We don't see any thrombus here, but probably a pannus of the valve. And finally, we may have cases with just a mild increase of the gradient, in this case 10, and the second with a mean gradient of 6. But in both cases, after thrombolysis, we have the true evaluation of a prosthesis that had clearly a thrombosis. So why this is so important? Because 20 years ago, we decided to have data concerning the presence of up to 24 of the cases with a proven prosthetic mitral valve that have a normal Doppler mean gradient at rest. And for this reason, we had clearly the demonstration that this not occur in single disc, which there is a linear regression between the opening angle and the gradient, while in bileaflet prosthesis, we may have cases in which the opening angle is clearly pathologic, but the gradient is normal. This is a sort of a honeymoon phase in which there are two situations. The first is quite obvious. The alteration is mild, and so the gradient is not important. But you may see in this second case that the mean gradient is 2, but one of the leaflet is completely stuck. So this is extremely important, and for this reason, we had a lot of data concerning simulation with the Politecnico of Milano, and we demonstrated that the key diagnostic role is to have not only the Doppler gradient, but also the disc motion. Just a first paper, 2000, in which we suggested to have the cine fluoroscopy, the Doppler, and when useful, also the TOE. So the first point is in how many cases we may demonstrate the normal motion of the disc. For the mitral valve, if we consider a cinefluoroscopy 100%, we have the TT with an accuracy of 77% and the TOE 100%. So you may see these two images, and probably nowadays much more. But anyway, when we see the aortic valve and we evaluate the feasibility for the aortic motion of the disc, this is not the same, because in both bileaflet and single disc, the accuracy with the TOE or the TT is not so good, and we need to have a cinefluoroscopy. Nowadays, we have a lot of other modalities, such as the CT, the 3D echo, and obviously the disc motion may be examined not only with the echo, but also with new techniques. Why this is so important? This is particularly important, particularly for the high prosthetic aortic gradients. We may have three main situations. The low size models, a very frequent phenomenon, the true prosthetic mismatch, or the obstruction due to pannus or thrombus. And in this regard, as we know, I can't go into details, we may have two confounding Doppler data and the problems that are the pressure recovery and the prosthetic mismatch. That's the reason why we should have the effective prosthetic valve area that is less than that of a normal human valve, and we need to have the body surface area. Anyway, to overcome these gradients, approximately 10 years ago, the group by William Zobby asked us a collaboration, and we clearly demonstrated that acceleration time may add a lot, both in absolute values, more than 100 milliseconds, or as acceleration time divided the ejection time. 2 years later, we also reevaluated the 100 cases, and in this new paper, you may observe that in normal cases, we have a 74 acceleration time, in the mismatch, 78, and only in the prosthetic valve obstruction, we have a value of acceleration time that was over 100. Moreover, moderate to severe intraprosthetic regurgitation was observed only in true obstruction. Therefore, we suggested in the guidelines to evaluate the acceleration time in the presence of a mean gradient that is altered to define whether or not there is a mismatch versus an obstruction. This was also received in the American guidelines, and when there is an alteration of the prosthetic aortic jet velocity, is very useful to add the acceleration time and all these values to have more details in terms of the gradients and the normality of the prosthetic. Going to our days, we also demonstrated that the identification of patients who require further assessment with TE and CT may require a first step that is generally the TT plus the fluoroscopy and the Doppler. And this provides prompt identification of patients who may require further imaging assessment and closer follow-up. In cases with true obstruction, we should determine whether or not there is a pannus or a thrombosis. The thrombus has a shorter duration from time of valve insertion, lower rate of adequate anticoagulation, while the pannus is much more frequent in aortic position. The thrombi are larger than pannus, and also they are a soft mouth, while the pannus has a soft mouth in a minority of the cases. Tanis demonstrated also that in thrombosis, restriction detected by fluoroscopy were observed in the majority of cases, while in pannus, the restriction by fluoroscopy was absent in approximately 20%, and also mass detection by TE was absent in the majority of cases. This is a typical case with TOE. You may observe the thrombus and obviously the alteration in the opening and also the closure of the disc, with also a very severe aortic regurgitation. However, nowadays in situation of inconclusive echo, CT may correctly detect the pannus of thrombus based on the Hounsfield units, and thrombus has a lower attenuation, as you can see in several examples in this slide. Just an example in a patient with a clear disc alteration at the level of the discs by CT, and also this sort of phimosis of this kind of alteration of the gradient by obtained by the 3D TOE. Very uncommonly, we may have also mitral valve prosthesis with pannus alone without thrombus. You observe in this case this linear alteration at the level of the opening of the disc, and may be very useful at transillumination from both sides of the prosthesis to see this altered image at the level of the site of this reach that we observe in the left ventricle. Unfrequently, we may have also intermittent obstruction. This has been first demonstrated by George Sutherland and Liv Huttel, and this is a typical case. You see, we are in a sinus rhythm, but in this bit we have the opening of the disc and the flow only in late diastole, while in another bit we have the opening of the disc throughout the entire cycle, and also the flow in the entire, in one of the two bits. In other cases, as in this case, you may observe by TOE that the disc is motion, stuck, and then it moves. So is an intermittent opening of one of the two discs, in this case due to a pannus. Rarely, this may also occur for the aortic prosthesis, and this is a rare case you may observe. Please note with the color Doppler, no regurgitation, severe regurgitation, no regurgitation, and so on. And this has been demonstrated to be linked to this mild alteration in the closure. So even this mild alteration of the disc closure may determine such a severe aortic regurgitation. So what to do in these cases? We are cases with a thrombosis, and there are data pro-surgery or pro-thrombolysis, also as a bridge to surgery. A very important point is how to perform a thrombolytic treatment. We demonstrated 20 years ago that we have not only the Doppler silent valve thrombosis, but also cases who are pseudo-responders after thrombolysis. Just an example. This is a case that refused the thrombolysis for 1 year, then later on he performed a thrombolysis, mean gradient 10, then 6. However, you may observe that the two discs are not normal. Even the gradient is normalized. And later on with heparin, we have the normality. So I can summarize my data concerning the leaflet motion and gradients during thrombolysis in a case with a patient who underwent an evaluation for paroxystic atrial fibrillation, was scheduled for atrial ablation with a bileaflet mitral prosthesis. This is the Doppler with a mean greater than 6. If you see, you may observe that we noted only one disk, and also the gradient is, even the gradient is normal. You may observe this very distorted jet. We immediately perform a TOE. You may observe that the mean gradient at TOE is 11. One leaflet is completely hypomobile, immobile, stuck, and the second one is normal with a thrombus. And we decided after the cinefluoroscopy that confirmed our data, we decided for a thrombolysis. And post-thrombolysis, you may observe a mean gradient of 2.5, so excellent result. However, even though there is a laminar flow now and not a distorted jet, and the gradient is normal, we observed that only one disk was normal, and we didn't see the second disk. So we have two possibilities: suboptimal visualization of disks or an abnormal motion of one disk. We perform another cinefluoroscopy. You may observe that the disk, even the gradient is normal, are altered. And later on, we perform other data. You may observe that after 2 days, we had the complete normalization during heparin therapy. So we perform another echo, and now we observe the two disks. So it was not a suboptimal visualization of disks, it was a true abnormal motion of one disk. So why this is so important? Because if we stop the procedure only on the basis of the gradient, we may risk not identifying suboptimal results and have a recurrence of thrombosis. So we need both the disc motion and the gradient. Degeneration by prosthetic heart valve. This is an update. We know that generally occurs after 7 or 8 years, and it is the freedom of alteration after 10 or 15 years is uncommon. Degeneration means that we may have one leaflet that may be stuck, calcified, as in this case. This is a case with an alteration of a perforation prolapse of one cusp, both in a anatomical view and in the Doppler that show the alteration. Alternatively, we may have a subclinical leaflet thrombosis in these cases, and thrombosis developing of any structural valve leading to dysfunction may affect these cases, particularly in biological prosthesis and after TAVI, in up to 15 of the patient, even though it's subclinical. In these cases, CT is extremely useful with hypoattenuated leaflet thickening, hypoattenuated affecting motion, and reduced leaflet motion. Just an example, you may observe in this case, after 6 months post-implantation of a TAVR, of a gradient of 34 mean gradient, and after OAC, you may observe the normalization of the gradient as well as the normalization of the morphology of the valve. We observe in biological prosthesis, as in this case, a very, very marked stenosis after several years of implantation, or this thrombosis. And you may observe how useful may be the TOE, both in 2D or in 3D, from both the LV or the surgical view. How to manage obstruction? Obviously, we may have a surgery in fibrolysis. I just had this slide. And nowadays, we know that we may have the surgery of the thrombolysis depending on several classes of recommendation. Generally, valve replacement is a class 1, while fibrinolysis, when surgery is not available or is a very high risk of thrombosis or in the right-sided prosthesis. And surgery may also or should be considered for large, more than 10 or 15 non-obstructive prosthetic thrombus complicated by embolism. We need in all cases to have an adequate anticoagulation, particularly with small non-obstructive thrombi. We try to optimize anticoagulation with interval of repeating imaging to monitor thrombus resolution, and in larger thrombus, an evidence of systemic invalidation surgery is generally recommended. Two examples, a very small thrombus, as you can see in this, and the large thrombus, and there is clearly a relation between the area of the thrombus and the risk of the patient, up to 47% in very high-risk cases when the thrombus is very, very large. So in critically ill patient, generally we have surgery when available, but if there are also cases in which we may prefer the thrombolysis. Even in cases with very small thrombus, as in these cases, however, we may have a contraindication. This is quite obvious in these cases in whom there is also a very large LAA appendage thrombus. Another point is whether or not leaflet hypomobility or immobility may determine the results, and we clearly demonstrated 20 years ago that in cases with a blocked leaflet or a hypomobile leaflet, we may have a success if the duration of symptoms is not so long, but in cases in whom the duration is more than 20 days, generally we may have also in a failure, particularly in blocked leaflet. And redo surgery is therefore considered in all cases with class 4 heart failure, but with a very high mortality, while in cases with functional classes 1 to 3, the risk is lower. It allows for replacement of older, more thrombogenic valves with newer designs. So this is clear an advantage of surgery. In 7 observational studies, there are no differences in complete restoration of valve function or depth between the two treatment strategies, but generally urgent surgery was associated with a significant reduction of thromboembolism, major bleeding, or recurrent. So it depends on the cases. And in other cases, under studies, they did not find a significant reduction in mortality with the thrombolysis over surgery. Finally, a few words concerning the PV leaks. We know that reoperation is generally the recommendation class 1, while transcatheter closure is considered in surgical high-risk patient, or depending also on the site and size of the paravalvular leaks, as in these cases. We have a lot of new devices, and there are some tips and tricks, not only surgical views, but also longitudinal views, trying to have the rocking motion, simultaneous vision from both sides, as in this case, and trying to have a color Doppler and a whole imaging that should be concordant in the exact position of the hole. This is an example of the importance of new tools. This is a patient with a severe paraprosthetic leaks in the posterior region. But if you see the 3D may add a lot, because this is not one hole, but there are two paravalvular leaks that you may observe both in terms of morphology and also of color jets. And finally, I can go into detail, but obviously percutaneous implantation paravalvular leak device is very, very useful in some cases, and the monitoring with all our methods, and particularly TOE, is particularly important. Thrombosis of the leaflets in bioprosthetic valve. Surgery is indicated in symptomatic patients with severe stenosis, generally independent of the etiology with low surgical risk, while in patients with higher prohibitive surgical risk, valve-in-valve procedure is reasonable. These are the guidelines. Reoperation is recommended, class 1. Reoperation should be considered in a symptomatic patient with significant dysfunction if reoperation is at low risk. And finally, transcatheter valve-in-valve implantation is in class 2A. But this is a new trend. We are trying to consider always the valve-in-valve as an alternative, particularly in older patients, and those with comorbidities who are at higher risk. We have a good experience, more than 200 cases for the valve in prosthesis, and for the aorta position, and approximately 40 in cases with the mitral position. And with this method, we may abolish the gradient. We have excellent results. This is a typical transeptal valve puncture with a valve-in-valve in a patient with a mitral valve stenosis and regurgitation. You may observe the excellent results in these cases with a very, very good results. This is another case. You may observe a very nice results, both in terms of morphology and also the normalization of the gradient. So in conclusion, how to define and manage the prosthetic valve dysfunction? We have a lot of data. Generally, it's a complication of mechanical but also biological valve. Identify the cause is critical to treatment administration, and the role of multimodality imaging in the diagnosis of dysfunction of the prosthesis is crucial, and allows not only an ideal diagnostic workflow, but also directs the best therapeutic strategy. So, my friends, thanks a lot for your attention from Milano. Bye-bye.
Thank you. Thank you so much, Professor Pepi, for your excellent presentation about this great problem with the prosthetic valve dysfunction. It is well known that the valve degeneration and the valve thrombosis of the prosthetic valve, it's a great problem. Unfortunately, Professor Pepi, your lecture is pre-recording, and thus he will not be able to accept any questions. But if you want some questions, we are available.
Well, I am online.
Okay.
Okay. I'm sorry.
Okay.
Sorry.
Someone tell me, Professor, that you are pre-recording. Okay.
It's really a pleasure.
It's fantastic. It's fantastic.
Thanks a lot for your invitation, and also to the chairman, and also to George for the invitation. Sorry, I prefer to have a pre-recorded just to have the video that has not any trouble with the slides.
Mauro is always precise and functional. So it's a characteristic which allows us to be with him in a very functional interaction for the last 20 years.
It's any question from the audience? Well, can I ask you something, Professor Pepi?
Oh, thanks.
As you mentioned, the valve degeneration rates, especially in the bioprosthetic valves, the range is coming from 0.04 to 2.2. And according to the valve thrombosis, it's about 0.4 to 2.2 patient per year patients. Also, did you have any important data if has changes according the material of the new valves?
Well, this is a very important data. Well, certainly the new valves theoretically may have a lot of advantages because of the different procedural that have been done by the companies. But really, what I observed, at least without any real important data in terms of statistics, is that even in cases with the new valves, we may have thrombosis. What we have tried to change in my hospital is to reconsider antithrombotic agents or warfarin in after bioprosthesis, because we have seen in several cases this problem. Obviously, there is not something scientifically determined. Anyway, I think that the subclinical thrombosis or even some cases of clinical thrombosis are more than we generally think.
May I take the opportunity to ask a practical question? Currently, the mean age of patients having TAVI is 80 to 83 years old. In a good percentage of those, there is also atrial fibrillation. Is there any necessity to keep going on NOACs, or in this scenario, is it better to use Coumadin?
Well, George, there are data discordant in the literature. We have seen in the majority that probably we have not very important differences between NOAC and warfarin, but in other, they prefer warfarin in terms of both in terms of hemorrhage and also in thrombosis. But what I think is that we may certainly utilize NOAC, because in this very old patient, this is much more practical and we should have more data on that. But probably the new data that we have seen just in few studies are towards the use of NOAC.
So we may safely, at the moment, use in this scenario the low dose NOAC in these patients having TAVI, and avoiding, of course, the additional or antiplatelets.
I think so. I think so.
Hari, if I may just make a comment further to Professor Athanasopoulos' comment with regards to the new DOACs now, and how do we consider them in the prevention of thrombosis, especially in the bioprosthetic or the prosthetic valves. You think the understanding of the mechanism of prosthetic valve dysfunction, thrombosis versus pannus, the degrees of each of the two mechanisms will really give a direction to how the drugs might be beneficial to that and make a more compliant and persistent to anticoagulant therapy without having the patients on Coumadin, irrespective of AF or not?
It's a very, very, very important point. I have not a sure. Well, I can say that we know that when there is a pannus, we may have frequently pannus and thrombus. This is much more common, obviously, in mechanical valves. So in those cases, we have probably surgery that is best, that has advantages in comparison with thrombolysis and in the anticoagulation. But if you are meaning what is important in bioprosthesis, I think that in those cases, pannus is not so frequent at all. And generally, we have to be more aggressive, I think, in antithrombotic agents. And when we abandoned that at 6 months or something like that for the aortic, probably is not so always safe. And we have to be more caution in the evaluation and monitoring of this patient. when we see any changes of the gradient, and also to see with the new machine, with the new ultrasound unit, the morphology of the valve. Because sometimes, at least in Italy, I see, well, the gradient is dead. But in biological valve, in some cases, even after 1 year, 2 years, or 3 years, so not waiting for 10 years, we have changes in the valve. So in these cases, we have to be more aggressive.
Thank you.
Okay, so I think that we had the privilege to have you with us, Mauro, and to provide to all of us this very well-structured contribution to this very difficult and interesting and ongoing task of handling prosthetic valves. Thank you so much. We have to thank also the coordinators, Professor Agathagelou, Professor Grassos, and looking forward to see you in London, probably, Mauro.
I hope so, and thanks a lot for inviting me. It is always a pleasure to see Athens from my laptop.
Okay, next time we'll be in physical presence. Also, Dr. Chiapras, the co-organizer, the organizer, thanks you cordially for the contribution. Okay.
Bye-bye.